So welcome to the case number 2 of the liver pathology slide review. It's an important case. Remember that you can access the whole slide images on Crosscope. You just have the info to get access at the bottom of this page. The case number 2 is a liver biopsy that is performed in a 50-year-old patient, 57-year-old patient with transthyretin amyloidosis. He has a heart disease that is due to the amyloidosis, and during the workup for an eventual heart transplant, the liver seems dysmorphic, and the clinicians want to know if there's also a cirrhosis, a liver disease, because if there is liver disease and cirrhosis, they will have to transplant both the heart and the liver. So it's a very important specimen with major clinical implications. And now we will look at the slides. You have here the slide of the biopsy. So we will have a quick look at low magnification. You have here the liver parenchyma. It doesn't seem fibrotic at this magnification. There is not an obvious alteration. Maybe some areas that look like a little bit nodular here. And when we go at higher magnification, you have here the hepatocytes. They look quite normal. The trabeculae here are rather thin. Maybe in some part of the biopsy, the trabeculae are a little bit thicker. Like here you have some minor sinusoidal dilatation, and it's like this throughout the whole sample. So this is the main sample, and now we will look the other fragments, and they are very important because they will lead us to the diagnosis. So on these separate fragments, you have here some nodular areas, regenerative areas with thick trabeculae, and here some areas with a sinusoidal dilatation, and you can see the trabeculae are thin. And you have a good example here on this fragment, here the nodular area, and here the area with sinusoidal dilatation. So to further characterize this sample, we can do some additional staining, and we will see first the red serious hematein staining. So you have here this staining that stains the fibrosis in red. It's an important staining because we remember the question from the clinician, is there fibrosis, cirrhosis? And you can see here at low magnification that there is not really significant fibrosis, so at least not cirrhosis. You don't see any fibrotic septa. We'll just have a closer look in some areas. You know, here you have the vein, the centrolobular vein. Maybe you have a minor perisinusoidal fibrosis. Maybe here are some fibrosis also, but it's not the appearance of an established cirrhosis. So it confirms what was our impression on the H&E. And if you want to go further into characterizing this lesion, you can also ask for another stain that may be useful. It's the reticulin staining, and we will now look at the staining. So here is the reticulin staining that will allow us to differentiate the regenerative areas from the areas with more atrophia with thinner trabeculae. And you have here on this staining, you have here nodular areas, and here the areas with the thin trabeculae. And we can go to other part of the biopsy. Let's look at this fragment. You have here the nodular area with thick trabeculae, and here adjacent the area with sinusoidal dilatation. So you have this aspect throughout the whole sample, and so it's easy to confirm the diagnosis of nodular regenerative hyperplasia. You have here the regenerative area, and again here the atrophic areas. So it's not a textbook case of nodular regenerative atypia, but it's a real life case. So diagnosis is not completely obvious, but you have to know how to recognize those cases, because you have to tell the clinician that it's not cirrhosis, it's a vascular disease, and it would probably vanish when you cure the disease that induce the nodular regenerative hyperplasia. Now, some key points about nodular regenerative hyperplasia. So it's a disease that may regress if you treat the etiological factors, and there is a lot of etiological factors. Do not try to know them by heart because they are numerous, but just there are some drugs. There is some also hematological diseases that may induce NRH. There is also some vascular disease, some thrombi in the portal vein that may induce a nodular regenerative hyperplasia. It's an important diagnosis to know because there is often a suspicion of cirrhosis in these patients. And it's an important diagnostic because you will have to rule out cirrhosis, and it will greatly impact the treatment of the patient, whatever the etiological factor is. Thank you.